Congestive heart failure and cardiomyopathy. Mark Bromley. PGY1. Case 1 is 63-year-old male presents with breathlessness x 3 days. Approach: HX. PMHX, MI 3 years ago. 4-vessel CABG. Asymptomatic since surgery with no complaints of CP. HPI. Over the last 3 months, the patient notes onset of shortness of breath while unloading groceries and walking stairs. 2 weeks ago, he was unable to complete his daily 1 mile walk at the high school track. He noted swelling in his feet and ankles. 4 days ago he woke at 2 a.m. short of breath and had to sleep in his recliner the rest of the night. He has been unable to lay flat in bed at night since then and has slept on 3 pillows. Yesterday, he became breathless walking from one room to another. He presents today with extreme shortness of breath. He denies chest pain. BP 108/52 P 140, irreg. I30 and labor temp 99 degrees Fahrenheit, height 58 inches, weight 210. General, breathless, moderately obese male in acute distress sitting upright complaining, "I am going to die. Please help me." Chest, scattered raunchy throughout, rails bilateral 1/3 lower bases. Cough is productive and frothy. CVS, tachycardia and irreg. Grade 3/6 systolic murmur at LSP, S3 gallop noted. JVP the jaw. ABID, liver palpable 3 cm below right costal margin. HJR. Extremities, 4+ pitting edema of lower extremities to the knees. Pulse is intact. Organization of CHF. Importance. Pathophysiology. Diagnosis. Etiologies, decompensation. Management. Cardiomyopathy. Importance: increasing burden. Aging population, improved survival, hypertension/CAD. Nationwide, heart failure affects more than 400,000 Canadians. 10% of those greater than 75. Greater than 50,000 new cases are diagnosed/year 1. Bad disease mortality at visits 1 year, 10 to 20%, 6 year, 60 to 80%. 20% new diagnosis. 80% repeat visit. Decompensation. Definition: CHF pulmonary edema. Inability of the heart to maintain adequate vital organ perfusion at normal filling pressures. Decreased exercise capacity. Associated neurohumoral endocrine changes, initially compensatory but ultimately maladaptive. Pulmonary edema. A condition associated with increased loss of fluid from the pulmonary capillaries into the pulmonary interstitium and alveoli. The heart is a pump that works together with the lungs. The heart is a pump that works together with the lungs. It pumps blood in 2 ways. It pumps blood from the heart to the lungs to pick up oxygen. The oxygenated blood returns to the heart. It then pumps blood out into the circulatory system of blood vessels that carry blood through the body. In HF, the pumping action of the heart becomes less and less efficient/powerful. The heart does not pump blood as well as it should. When this happens, blood does not move efficiently through the circulatory system. It starts to back up, increasing the pressure in the blood vessels, forcing fluid from the blood vessels into body tissues. Physiology: CO equals HRX stroke volume. SV equals preload plus contractility, afterload. Preload. Initial stretching of the cardiac myocytes prior to contraction. Afterload: the load that the heart must eject blood against. Aortic pressure. Hypertrophy is a mechanism that allows more muscle fibers to share the work. Stroke volume, contractility. Ability of a cardiac muscle fiber to contract at a given fiber length. Catecholamines, NOPI and EPI. Sympathetic stimulation, Ca++, neurohormonal activation. Jackson, G. et al. BMJ 2000 320 to 167 to 170. Copyright 2000 BMJ Publishing Group Limited. Norepi and mortality. Jackson, G. et al. BMJ 2000 320 to 167 to 170. Copyright 2000 BMJ Publishing Group Limited. Sympathetic activation. Jackson, G. et al. BMJ 2000 320 to 167 to 170. Copyright 2000 BMJ Publishing Group Limited. Remodeling post-me Jackson, G. et al. BMJ 2000 320 to 167 to 170. Copyright 2000 BMJ Publishing Group Limited. Classification of heart failure. Low output. Cardiac output is low, but demand for blood flow is normal. The heart is unable to meet this demand and fails. DX, IHD, HDN, dilated cardiomyopathy, valvular and pericardial disease. High output. High output heart failure. Cardiac output is normal or a little bit high. Demand for blood flow is abnormally high. Hypothyroidism, anemia, severe infections. The heart is unable to deliver the increased amount of blood and fails. DX, hypothyroidism, anemia, pregnancy, avenue fistulas, beriberi, and Paget's. RX, volume overload and correct the underlying disorder. Classification of heart failure. Acute. Me, acute valve dysfunction. Largely systolic. Sudden reduction in cardiac output often results in systemic hypotension without peripheral edema. Chronic. Cardiomyopathy. Arterial pressure tends to be well maintained until very late in the course. There is often accumulation of peripheral edema. Chordae tendineae rupture. Large enough area of ischemia. Classification of heart failure. Right-sided, right ventricle. Pulmonic stenosis or pulmonary hypertension. When the right side of the heart starts to fail, fluid collects in the feet and lower legs. As the heart failure becomes worse, the legs swell and eventually the abdomen collects fluid, ascites, hepatic congestion. Weight gain accompanies the fluid retention and is an excellent measure of how much fluid is being retained. Left-sided, left ventricle. Left ventricle is mechanically overloaded, aortic stenosis, or weakened, post-me. When the left side of the heart starts to fail, fluid collects in the lungs, orthopnea/PND. Breathing becomes more difficult, and the patient may feel short of breath, particularly with activity or lying down. This extra fluid in the lungs makes it more difficult for the airways to expand on inhalation. O2 diffusion. However, when heart failure has existed for months or years, biventricular failure usually results. For example, patients with long-standing aortic valve disease or systemic hypertension may have ankle edema, congestive hepatomegaly, and systemic venous distension late in the course of their disease, even though the abnormal hemodynamic burden initially was placed on the left ventricle. Classification of heart failure. Systolic. The heart has difficulty contracting and pumping out enough blood. Weakness, fatigue and decreased ability to exercise. Ejection fraction equals stroke volume, and diastolic volume. A normal ejection fraction is greater than 50%. Systolic heart failure has a F less than 50%. Diastolic. The heart is unable to fill properly during diastole. Filling pressure. This impedes blood filling into the heart back up into the lungs. CHF symptoms. In patients greater than 75 years, women, HDN. Ejection fraction is normal. Classification of heart failure. Directional heart failure. Backwards heart failure. The ventricle is not pumping out all the blood that comes into it. ventricular filling pressure and systemic or pulmonary edema. In fact, the heart can only meet the needs of the body if the ventricular filling pressure is high. Forward heart failure. The heart is not pumping out enough blood to meet the needs of the body. Blood reaches the kidneys, they conserve salt and water, which contributes to excess fluid retention and edema. Forward failure also decreases the blood flow to various organs, causing weakness and fatigue. Diagnosis. History. Physical. EKG. CXR. History. Prior heart disease, dyspnea, PND, orthopnea, fatigue, cough, bloating, angina, weight/girth, nocturia. Precipitants. Salt, non-compliance, new meds, NSAIDs, palpitations, angina. Comorbidities. COPD, renal disease, DM. PHRRRJVPHJR precordial exam, lungs, peripheral edema. Apical impulse. Location, size, sustained. 45 LLD position, exp. Loud P2. S3, ventricular vibration with rapid filling. Low-pitched, bell, 45 LLD position. Lungs. Cracks, wheezes. Peripheral edema. Beware of Andhra Pradesh films and poor inspiration, FP. Precision improves with further training, i.e. Precision improves with further training, i.e. medical students, residents, staff, cardiologists. Precision improves with further training, i.e. Precision improves with further training, i.e. medical students, residents, staff, cardiologists. Case 258F with known idiopathic dilated cardiomyopathy. Cardiac CAT, 05, and coronaries of 35%. Meds, ACE-I, Datix, digoxin. Sobo X 3 weeks. OE, displaced MPI. Soft S3. Presacral edema, case 370M, obese Sobo and fatigue X 3 months, no orthopnea/PND. PMHX, smoke X 40 pack years, HTN, polycontrolled, DME. OE, BP 180/100ths. Sustained MPI. Bilateral rails. Mild/moderate preterb edema, X-ray cardiomegaly redistribution, cephalization. LV or hypertrophied ventricular wall. Cardiothoracic ratio greater than 50%. Redistribution, cephalization. Systolic dyseffects and filling pressure. Upper lobe vessels greater than lower lobe vessels. Blunting of costophrenic angle. Peribronchial cuffing. Calibi lines. Peribronchial cuffing. First, strike for the jugular and let the rest go. Oliver W. Holmes Jr., Etiology Dysrhythmia Tachybrady. Diastolic filling time plus/atrial kick. CO. Coronary perfusion. Myocardial load to demand. Brady. HR. CO equals S/HR. Infection anemia systemic met demands pulm infection equals O2. Tachycardia. Anemia. Isovolumic hemodilution. CO meet O2 demands. Coronary O2 delivery. Acute valvular dysfunction. Pregnancy. Demand for CO. Acute myocarditis. Contractility. Acute valvular dysfunction. 2O2me. Preload or afterload. Pharmacological to supply pulmonary hypertension. Inotropic effects. NAR, H2O retention, etiology decompensation/causes of exacerbation. Failure, forgot medication, arrhythmia/anemia, ischemia/infarction/infection, pneumonia. Lifestyle, taken too much salt. upregulation of CO, pregnancy, hypothyroidism, renal failure, embolism, pulmonary. Inappropriate treatment, failure to seek care. 25%, 10%, 25%, other 10%, 10%, 20%. Case 1 management. A 63-year-old male presents with breathlessness x 3 days. Approach, HX. PMHX, MI 3 years ago. 4-vessel CABG. Asymptomatic since surgery with no complaints of CP. HPI, over the last 3 months, the patient notes onset of shortness of breath while unloading groceries and walking stairs. 2 weeks ago, he was unable to complete his daily 1 mile walk at the high school track. He noted swelling in his feet and ankles. 4 days ago he woke at 2 a.m. short of breath and had to sleep in his recliner the rest of the night. He has been unable to lay flat in bed at night since then and has slept on 3 pillows. Yesterday, he became breathless walking from one room to another. He presents today with extreme shortness of breath. He denies chest pain. Management: treat the maladaptation. LMNOP: vascular resistance. Sympathetic tone. Total blood volume. LMNOP. Management: nitrates, O2 ventilation assist devices, acidetics. Morphine. Inotropes. Airway/breathing non-rebreather face mask delivering 100% O2. Once initial therapy has begun, oxygen supplementation can be titrated in order to keep the patient comfortable and arterial oxygen saturation above 90%. O2 increases PCWP. NIF. If respiratory distress and/or hypoxia persist, consider non-invasive PPV. Preload, afterload, and left ventricular performance. Meta-analysis of 15 clinical trials, mortality and intubation with NPPV compared to conventional therapy. Patients who fail/do not tolerate/have contraindications to NPPV should be intubated. Positive end expiratory pressure is often useful for improving oxygenation. Cardiogenic pulmonary edema emergency department. Multicenter RCT. 130 pints. Cardiogenic pulmonary edema. Emergency department. Medical therapy plus O2, 65 pints. Non-invasive pressure support ventilation, 65 pints. Primary outcome, need for intubation. Italian study, 5 departments. Loop tactics now and H2O excretion useful in volume overload. Rapid onset. Mild vasodilator. Half-life in CHF, be careful. Depletion of K+ and Mg++. Loop tactics dosing, not well established. High-dose Lasix and low-dose nitro has worse outcomes than low-dose Lasix and high-dose nitro. Morphine controversial, weak vasodilator, risk drive. ICU admissions, or equals 3, Saketi. Anxiolytic. Nitrates. Preload at low dose. Afterload at high dose. Nitrates, Rutesel/spray, 0.1 to 0.4 mg, 5 minutes, x3. 50 to 100 micrograms per minute. IV drip, 5 to 10 micrograms per minute. Titrate to effect. 100 to 200 micrograms. Transdermal. Peripherally shut down. Unreliable absorption. Contraindications, cautions. Viagra. RV-ME. Fixed aortic lesions. Case 467, MSOB visibly distressed 96 28 200 110 75% ORA. PMHX, HTN, DM2. EKG. Nitroprusidate direct smooth muscle relaxant. Balanced reduction of pre/after load. Continuous pressure monitoring, good. Avoid hypotension. Case 567, MSOB visibly distressed 96 28 140 90 75% aura. PMHX, HTN, DM2. Meds, inconsistent. Natriuretic peptide Jackson, G et al. BMJ 2000 320 to 167 to 170. Copyright 2000 BMJ Publishing Group Limited. Nasiritide recombinant BNP aldosterone endothelin. Na and H2O excretion, no reflex tachy. Good for nitro contraindications. VMAC randomized, double-blind 489 in patients. 4 nasiritide versus 4 nitrates versus placebo. PCWP and dyspnea. Improvement in PCWP, 2 mm Hg at 6 hours. No change in dyspnea. Problems. Nitro dosing. Prolonged hypotension. Noted patients. Industry-sponsored, vasodilator therapy, nasiritide. Efficacy phase. 432 patients. In the efficacy phase, 127 patients underwent hemodynamic monitoring with a pulmonary artery catheter. A 6-hour infusion of nasiritide, 0.015 and 0.03 micrograms/kg per minute, decreased pulmonary capillary wedge pressure. 6 and 10 mm of mercury versus N of 2 mm of mercury for placebo. Improved the clinical status in a greater number of patients, 60% and 67% versus 14%. Comparative phase. 305 patients. Randomly assigned to nasiritide or standard vasoactive agents for 7 days without hemodynamic monitoring. Compared to standard treatment with a single vasoactive agent, dobutamine, milrinone, nitroglycerin, or nitroprazide A. Nasiritide produced a similar significant improvement in clinical status and reduction in dyspnea and fatigue that persisted during the entire infusion period. Asymptomatic, dose-related hypotension was the most common side effect. RR from meta-analysis, 1.74. Death within 30 days tended to occur more often among patients randomized to nasiritide therapy. 35, 7.2%, of 485 versus 15, 4.0%, of 377 patients. RR from meta-analysis, 1.74. 95% confidence interval, C, 0.97 to 3.12, P equals 0.059. Hazard ratio after adjusting for study, 1.80. 95% C, 0.98 to 3.31, P equals 0.057. Vasodilator therapy nitroglycerin, preload afterload. Nitroprazide A, afterload. Nasiritide, BNP. ACE inhibitors clear long-term benefits. Vasodilate. Block aldosterone. Bradykinin system. Remodeling. Take longer to work than nitrates. Peak effect 45 minutes. Effective ACE I Jackson, G et al. BMJ 2000 320 to 167 to 170. Copyright 2000 BMJ Publishing Group Limited. Placebo-controlled, randomized, double-blind study. Placebo-controlled, randomized, double-blind study of intravenous enalapril efficacy and safety in acute cardiogenic pulmonary edema. The purpose of this study was to evaluate the efficacy and safety of a single 4-2-hour infusion of enalapril at 1 mg. Placebo-controlled, randomized, double-blind study. 20 Swiss francs patients, NIHA class 3 or 4. Compared with placebo, enalapril at pulmonary capillary wedge pressure, minus 37% versus minus 10%, P equals .001. Diastolic and mean systemic blood pressures, minus 21% versus 0%, P equals .009, and minus 18% versus minus 1%, p equals 0.026. Diastolic and mean pulmonary blood pressures, minus 21% versus minus 8%, p equals 0.040, minus 18% versus minus 9%, p equals 0.046. Brachial and renal resistances, minus 44% versus minus 14%, p equals 0.017, and minus 22% versus minus 2%, p equals 0.014. Brachial and renal blood flows, plus 77% versus plus 8%, p equals 0.036, and plus 12% versus 0%, p equals 0.043. Arterial oxygen tension, plus 2% versus minus 16%, p equals 0.041. Arterial oxygen saturation, plus 1% versus minus 2%, p equals 0.045. Enalaprilat did not affect CO or carotid or hepatosplenectomic hemodynamics. Excluded those already on ACE-I. BNP. Why do we need another diagnostic test? How uncertain are we? Diagnostic uncertainty. How uncertain are we? How uncertain should we be? ER docs are rarely wrong when they rate the probability of HF as very high or very low too. ER docs are uncertain of the diagnosis in the in-betweeners, 30% too. The degree of clinical certainty, or uncertainty, is determined by comparing the clinical impression with an independent validated criterion, gold standard. Because there is no validated criterion standard for the diagnosis of HF, previous natriuretic peptide studies have compared the ED diagnosis with a retrospective diagnosis by two cardiologists who reviewed the medical records and were blinded to natriuretic peptide results and ED diagnoses. This unvalidated criterion standard has been assumed, although never proven, to be more accurate than the diagnostic impression of physicians in the ED. BNP. Ventricular pressure and stretch. Ventricular pressure and stretch. Pro-BNP, anti-BNP spec and BNP sense. Breathing not properly. Prospective, blinded. 1,586 spines presenting with acute dyspnea. ED study. Bedside assay. Gold standard equals 2 cardiologists. Breathing not properly. Breathing not properly. Add. Breathing not properly. Prospective diagnostic test evaluation 7 centers 1,586 patients. BNP, blinded. Gold standard, cardiology chart review. 97% certainty by ED physician. At 80% EP certainty. Sense, 49% specificity, 96%. At 100 pg/ml. Sense, 90% specificity, 73%. ADV. Breathing not properly, analysis. BNP brings us closer to the gold standard. Low prob EP. 17% had CHF. 90% would have been corrected by BNP. High prob EP. 4% did not have CHF. 80% would have been corrected by BNP. Uncertain EP. BNP correctly classified 74%. Misclassified 7%. BNP. Levels less than 100 pg/ml may prompt clinician to focus on alternative diagnosis, COPD. Reasonable neg-pred value. Prognostic value. Question mark variation with age/gender/kidney FXN. Prospective, randomized, controlled. Single blind. 452 pints with dyspnea. Diagnostic strategy, BNP, VRS standard assessment. Told DP if 100 Swiss francs unlikely, greater than 500 Swiss francs likely, 100 to 500 indeterminate. Endpoints, time to DC and total cost. Safety, similar. Conclusion: BNP improved evaluation, thereby improving time to DC and cost. No change in safety. BNP strong prognostic indicator in symptomatic and asymptomatic individuals. Death or cardiac death. Additive to LIF. Cardiomyopathy. http://www.medmovie.com/database/medmovie-redirect.asp. Client ID equals 27. Case: previously well 10-year-old girl presents with 2 weeks of progressive right-sided ABD pain. General malaise. Mild fatigue on exertion. Parents report mild lethargy, pallor and decreased PO intake over same period. Shallow rapid breathing, worse when reclining at night. 37.8 OC 123 24 94 54. Pale irritable. Keen, MMM. No adenopathy. CVS, regular S1 S2, no murmur, PPPX4, no edema. Chest, A equals a slight decrease at bases. ABD, palpable liver edge below umbilicus. EKG, sinus tach, loud, flattened T waves, decreased voltages, post-myocarditis. Dilated cardiomyopathy. Most common CM. 30% idiopathic. Hereditary. X-linked, dystrophin gene. Booze. Heavy metal. Drugs. Infectious. Viral. Chagas. Postpartum. Collagen vascular disease. Glycogen storage disease. Thiamine, PO4, zinc deficiency. Amyloidosis. Neuromuscular disorders. Dilated cardiomyopathy. Biopsy helpful for etiology. Rx same as other CHF. MDC, metoprolol in dilated CM. 34% reduction in death. Multicenter myocarditis treatment trial. No benefit of corticosteroids and azathioprine for Rx of biopsy proven inflammation in dilated CM. HCM inappropriate hypertrophy without stimulus usually asymmetric. 4% mortality per year, sudden death. HCM 50% familial, dominant inheritance, mechanism ABN-CA++ kinetics. ABN sympathetic stim. ABN coronaries. Subendocardial ischemia. Structural ABN, HCM. 25% first relatives of HCM. Usually third decade, not always. M greater than F. HCM, presentation sudden death dysrhythmia CHF presyncope, syncope. Angina, HCM CHFSXOA, JVP, prominent awave double impulse pulse. PMI laterally displaced and increased. SEM/HSM. Split S2. HCM genetic studies ECG echo LV outflow gradient greater than 50 mm of mercury. Diastolic dysfunction. Hope, septum greater than 1.4 to 1 ratio to post wall. HCM, approach/management ABCD normal Swiss franc to Canadian dollar Rx myomectomy. Catheter septal ablation. MV replacement. ICD. B blockade. CCB. Antiarrhythmias. Restrictive least common CM incidence, likely underdiagnosed. Poor prognosis. Cardiomyopathy. http://www.medmovie.com/database/medmovie-redirect.asp. Client ID equals 27. Restrictive idiopathic restrictive cardiomyopathy. Endomyocardial fibrosis. Low eosinophilic endomyocardial disease. Secondary restrictive cardiomyopathy. Radiation. Hemochromatosis. Amyloidosis. Scleroderma. Carcinoid heart disease. Glycogen storage disease of the heart. Diagnosis: chest X-ray, electrocardiogram. Absence of cardiomegaly, normal cardiac silhouette. CHF. Electrocardiogram. LBBB common, RBBB possible. Low voltage. Non-specific STT changes. Various arrhythmias. Chamber enlargement. Echocardiography: normal to symmetrically thickened walls. Rapid early diastolic filling, slow late diastolic filling. Normal or slightly reduced ventricular volume and systolic function. Cardiac catheterization. Elevated ventricular end diastolic pressure. Dip and plateau configuration of the diastolic portion of the ventricular pressure pulse. Normal to slightly decreased ejection fraction. Prominent X and Y descent. Endomyocardial biopsy may detect typical eosinophil infiltration in the inflammatory stage. May detect myocardial fibrosis in later stage cases. Negative findings do not exclude diagnosis. Treat underlying cause if possible. Therapy similar for other causes of CHF. Consider anticoagulation as prone to stasis. Thromboembolism. Thanks Sean for the resources. References. Kostup W.J. Congestive heart failure, what can we offer our patients? Mars 2001 165 8, 1053-5. Shwami. B-type natriuretic peptide for diagnosis of heart failure in emergency department patients, a critical appraisal. Academia GMed 2004 11 to 686-91. Risk of HF after AMI Jackson, G. et al. BMJ 2000 320 to 167 to 170. Copyright 2000 BMJ Publishing Group Limited.